Hello, and welcome to From the EBPL Archives, Encore presentations from the East Brunswick Public Library. I am your host, Melissa Hosick. This event was presented as part of our Just for the Health of It initiative. Just for the Health of It is a proprietary health literacy program developed by the East Brunswick Public Library to promote health literacy in Middlesex County. To learn more, visit justforthehealthofit.org. Now, enjoy the program.
Welcome and thank you for joining us this afternoon for today's Lunch and Learn with the Doctor on Hematologic Malignancies. My name is Kathy Chern and I am a Consumer Health Librarian at East Brunswick Public Library. Today's program is brought to you by Regional Cancer Care Associates Central Jersey and the Library's Just for the Health of It initiative to promote community health and wellness. Today's speaker is Dr. M. Hossein Kazemi, Medical Oncologist and Hematologist, Regional Cancer Care Associates Central Jersey. Please be aware that this talk is being recorded. Please keep your microphones muted and your webcams off. The recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. The doctor will answer questions at the end of the talk. The doctor will not be able to offer personal medical advice to attendees during this program. And without further ado, I will turn things over to Dr. Kazemi.
Good afternoon. Thanks for joining. I'm excited to be able to talk about novel advances in field of hematological malignancies. In this talk, we'll first talk about lymphomas and cellular therapy in treatment of lymphoma, a multiple myeloma, a brief overview of what it is and how it is treated, and finally, just briefly touching upon MDS and AML. Next slide. So, what is lymphoma? Let's first talk about lymphatic system. Lymphatic system is one of the most important parts of the immune system. It's basically like a surveillance system, as you can see in the picture, spread all over the body. What it does is that in our body, all cells are basically surrounded by a fluid, and this fluid constantly circulates through the lymphatic system. And within the lymphatic system, we have these areas of lymph nodes within the lymphatic system. If we can go to the next picture. And here you see like a close-up of a lymph node. Within each lymph node, there are many different types of immune cells, mostly lymphocytes. And we have several types of lymphocyte, B cell, T cell, NK cells. And these, the purpose of these lymphatic system and lymph nodes is basically closely monitoring what's happening in the body. And this is one of the ways our immune system becomes aware if there is any infection in the body. Basically, if any virus or bacteria or fungi has entered any of the tissues, some of those pathogens will end up circulating through the lymphatic system. The immune cells can detect them as the lymph flows through the lymph node and starts a reaction to them. Also, our immune system is very good at detecting cancer. Cancer cells are different from normal cells. They have different set of proteins and such. So a lot of times cancer develops within the body, but before it grows, before it spreads, it's destroyed by our immune system. Next picture. So I'm sure most people have had a strep throat or sore throat during childhood, and many of us remember having swollen and painful lymph nodes in our neck. This is what happens when you get an infection. The pathogen goes to the lymph node, immune cells recognize the pathogen, they start reacting, they start dividing, they start calling other immune cells for help. And basically, because the number of the cells within the lymph node increases rapidly, the lymph node becomes enlarged and painful. and this is what we call lymphadenopathy. It can happen as a result of any sort of inflammation, infection, cancer, and any other reason that basically makes the immune system react. If at some point during the life, for whatever reason, one of the cells within the lymphatic system, one of the lymphocytes becomes malignant, basically gets out of control, starts dividing unregulated, then we will have lymphoma, cancer of the lymphocytes. Next slide. So the most common type of the lymphoma comes from a lymphocyte called B cells. Basically, around 85% of the lymphomas are as a result of this specific type of the B cell. But there are many different types of B cell lymphoma. It depends. You can see here a B cell goes through, like during its normal life cycle, it goes through the lymph nodes before it's exposed to pathogen. It's called a naive B cell. As it's exposed to pathogen, it goes through changes. Finally, it might change. It might turn into a memory B cell in case that pathogen enters the body again in future, or a plasma cell, which makes antibodies to fight the infection. Depending on which stage of the B cell life this cancerization, if you call it, happens, you will end up with different kind of lymphomas. And these different type of lymphomas have basically different treatments, different outcomes. So it's for us, for oncologists, when we see a patient for lymphoma, it's very important to figure out exactly what sort of lymphoma the patient has. That dictates the next steps in treatment. Next slide. So why do people get lymphoma? The vast majority of cases, we can't figure out why. We still don't know why. But there are some certain risk factors that greatly increases the risk for developing lymphoma. Certain viral infections, HIV, greatly increases the risk for lymphoma, partly because it basically disables the immune system. So the immune system cannot recognize the cancers that are rising within itself. Hepatitis C can cause certain kinds of lymphoma. There are other less well-known viruses, such as Epstein-Barr. Epstein-Barr virus is a very common virus. Many of us have been exposed to it during childhood. In some people, in a small minority of people, it may lead to lymphoma. We don't know why. It's harmless in vast majority of people, and some people might end up causing lymphoma. There are other viruses such as HTLV1, which is more common in South America and Far East, which can cause a rare kind of T-cell lymphoma. The second risk factor is compromised immune system. As I said, one of the important functions of immune system is basically monitoring not just for pathogen, not just for foreign organisms, but also any abnormal cells in the body and any cancer cells. So when, for whatever reason, a person has a compromised immune system, the risk of cancer increases. People who have had kidney transplant or liver transplant or heart transplant, these people will need to take immunosuppressive medications, so the body does not reject the transplant, but a side effect is increased risk of cancers, including lymphoma. And finally, most important risk factor is age. Majority of cancers, including lymphoma, they are diseases of older people. The incidence increases sharply after age 60 and especially 70. Next slide. So, what are some symptoms of lymphoma? Usually, the most common symptoms that prompt a referral to an oncologist Basically, first is a swollen lymph node. As we talked about earlier, anything that makes the immune system react, anything that makes the number of cells within the lymph node increases, can cause a swollen lymph node, a large lymph node. Now, the vast majority of large lymph nodes are benign. They are a reaction to an infection, and they will resolve quickly. But if a large lymph node does not go away and it persists within the course of weeks, then that requires attention. Fever and night sweats. Well, fever, we all know it's abnormal. So usually when people start getting fever, they do seek medical attention. One other symptom that can happen in people with lymphoma is feeling of cold sweats at night. Basically, sometimes patients tell us that they wake up in middle of night, like drenched in cold sweat, sometimes so bad that they will have to change the sheets. And it's just because of the cancer cells excreting cytokines and chemicals that basically causes this fever and cold sweats. Loss of appetite and unintentional weight loss, very common in all sorts of cancer, especially lymphomas, and excessive fatigue, feeling that people do not have energy. As you can see from this list, unfortunately, most of these symptoms are fairly non-specific, and sometimes because of this reason, it takes a long time for people to be diagnosed. Next slide. So, what do we do when we have a suspicion for lymphoma? First and most important part is talking to a patient, getting a detailed history, and see if they have any risk factors, if there are any other explanations for the symptoms, and doing a physical exam. Is there any large lymph nodes? The next step is basically to consider a biopsy of the lymph node. And it's usually good to talk to a hematologist, oncologist, before attempting a biopsy. Biopsy for lymphomas can be a little bit different from biopsies for other cancer, in that it's very important where exactly to biopsy, choosing the site of biopsy, the type of biopsy, whether you need to use like a needle biopsy or maybe do a surgical biopsy to remove the whole lymph node. Sometimes it's best to consult with an oncologist even before a diagnosis is made, to make sure that the biopsy is done in the right way. And of course, a very important step is basically see how widespread the disease is. And usually these days we do a PET scan. A PET scan is a form of a scan that picks up how active the cells and tissues in the body are, basically how metabolically active they are, how fast they are consuming sugar. Cancer cells use a lot of energy, so they pick up a lot of sugar. So they inject people with this sort of glucose molecule that's tagged, and it can be detected via this PET scan. So if a certain area lights up within the body, it tells us that there is something wrong in that area. And in some cases, depending on the exact type of the lymphoma, we might need to do a bone marrow biopsy, see if there is any evidence of lymphoma in the bone marrow, or even a lumbar puncture, which is basically taking a small sample of the fluid that's around the spinal cord. But that's only in some cases of lymphoma. Next step. Next slide. So, classification of lymphoma is actually fairly complicated, and it's constantly evolving as our understanding of lymphoma evolves. But a very quick and practical way of thinking about it is basically, first of all, lymphoma is divided to Hodgkin and non-Hodgkin lymphoma. Hodgkin was a physician actually in a long time ago that first recognized this specific type of lymphoma. It was the first type of lymphoma that was described in the literature. And also it was one of the first types of lymphoma, and actually cancer, that we managed to cure with chemotherapy alone. So it has a special place within the heart of any malignant hematologist. The vast majority of lymphomas are non-Hodgkin lymphomas. And for that, we divide them into aggressive lymphomas and indolent lymphomas. Usually when people think about cancer, they think about this relentlessly advancing disease that requires treatment right away, otherwise it will progress quickly and can cause a lot of problem. And that's certainly true about a lot of cancers. But indolent lymphomas are different in that they can remain basically unchanged, and they can just remain stable, not growing, sometimes for months, sometimes for years, sometimes for decades. So sometimes people have like incidental diagnosis of an indolent lymphoma, and the most common type is follicular lymphoma. They go for a CAT scan for some other reason. A mass is picked up on the CAT scan, they biopsy, they see it's follicular lymphoma. Or they just palpate a lymph node in the neck, in the armpit, the biopsy is follicular lymphoma. Most of the times, if follicular lymphoma is not causing any problem, if it's not causing symptoms, a lot of times we can just monitor it. And people might stay basically on observation for a very long time. Of course, a lot of times, even indolent lymphomas can progress. The lymph node, the mass can become large. It can press on other tissues, cause problem. Sometimes it can start spreading like in the body, going to the bone marrow, causing problems. Of course, in that case, you will need treatment. And they are usually responsive to treatment. A lot of times we give people a gentle treatment. It controls the lymphoma for years. They might have a recurrence, then we treat them again. So it's sort of like an indolent lymphoma is best described as a marathon. It's something that you have to think about it as living with long term, so sort of a chronic disease, like diabetes or hypertension. Of course, in sometimes like in 20-30% of cases, eventually an indolent lymphoma might completely change its behavior and transform into an aggressive lymphoma. And aggressive lymphoma is closer to what you think when you hear about the word cancer, the word lymphoma, meaning that it's dividing rapidly, it's growing rapidly. Sometimes some of the most aggressive lymphomas, sometimes the cells double within a matter of days, and it requires treatment. And the vast majority of aggressive lymphomas, and there are many kinds of aggressive lymphomas, diffuse large B-cell lymphoma, or DLBCL, is the most common, but there are many types of aggressive lymphomas. Usually the first step in treatment is chemotherapy, combination of 3-4 drugs depending on the exact subtype of lymphoma. Treatment is given for 4 to 6 months. And let's talk about diffuse large B-cell lymphoma, because that's the most common, and use it as like the example. Diffuse large B-cell lymphoma, 2/3 of the cases we manage to cure with first-line chemotherapy. So 2/3 of them are cured, and they will continue to live their normal life and won't have to worry about this. Again, in 1/3 of the cases, either the lymphoma doesn't respond, or it might come back after some time. Sometimes it comes back very quickly. Sometimes after a few years, it might come back. And up until a few years ago, relapsed lymphoma, like what could you do for a relapsed large cell lymphoma? The best we could do was bone marrow transplant, but that's tricky. Not everybody is a candidate for bone marrow transplant. It's not very easy to tolerate, so that's basically restricted to younger patients. to patients who don't have other medical problems. And it didn't help all patients. Eventually, maybe 30–40% of people who could get bone marrow transplant would stay in remission after bone marrow transplant. So for a lot of people, relapsed lymphoma was basically a terminal diagnosis, unfortunately. But fortunately, in the past few years, there has been a revolution in treatment of relapsed lymphoma. Next slide, please. Just talking about the relative frequency, so you get an idea. As we talked about, we have this minority of cancers that are Hodgkin lymphomas. Hodgkin lymphoma also is very curable. It's sort of aggressive in behavior, but the vast majority of it, like more than 90% of it, 80–90%, can be cured with chemo. Then you have all the other lymphomas. Diffuse large B-cell lymphoma, the most common, followed by follicular, followed by all the other lymphomas, which there are many of them. Next slide. So, as I said, there have been many progresses in treatment of lymphoma. The most dramatic one, by far, has been CAR T-cell treatment, and it stands for chimeric antigen receptor T-cell. And it's a unique treatment, a unique advance, meaning that unlike other treatments, unlike other advances so far, this is a living drug. This is a live drug. This is actually a cellular therapy. And I don't know if you have seen it within the news or not. There was a New York Times article who documented the history of CAR T-cell treatment, which I encourage you to read. It's very, very interesting. One of the best examples of scientific progress. The idea before CAR T-cell treatment, behind CAR T-cell treatment, if we can go to the next slide, is to make the T-cells from the patient's body, basically harvesting the T-cells, getting them to the lab, genetically engineering them so they can recognize the cancer cell, and then returning it to the body so this T-cell, this lymphoma, this lymphocyte can recognize the cancer cells and destroy them. And it took a long time to develop. The first time anybody had this idea was like in the early 90s. And at that time, when that investigator tried to basically get funding from it, it was actually rejected. He tried to take it to pharmaceutical companies, and they basically deemed it not practical. But fortunately, he persisted, and it took 17 years until they did the first human trial of T cells. And the picture I showed you was one of the very first patient, Emily Whitehead. If you search that name, the Emily Whitehead Foundation, it was a child that was diagnosed with a very aggressive form of lymphocytic leukemia, ALL. And basically, she had exhausted all treatment options. So she was actually referred to hospice for comfort care, and she was days from dying, where her parents took her to Philadelphia, to UPenn. And there she was one of the patients who first of all received the CAR T-cell treatment in CHOP Hospital. And I greatly encourage you to read that paper, that New York Times article. Initially, she became very, very sick after that CAR T-cell treatment, and they later figured out why. But within days, she made a miraculous recovery, and it was 9–10 years ago, and to this day, she remains in remission, and she is considered cured of her cancer. And there are many interesting stories from the origin time of the this CAR T-cell treatment. One of the other patients that was treated early in the early days of CAR T treatment When he got the treatment, after 30 days, they did a bone marrow biopsy to look for evidence of cancer. He was an older gentleman who had another sort of lymphoma, CLL, and they didn't find any evidence of cancer, not even a single cell. And the team actually, initially they said, oh, there must have been a mistake. Probably the samples got mixed up. There is no way that all the cancer cells have disappeared. And they actually, they had such a hard time believing it that they repeated the bone marrow biopsy a week later. And there's still no evidence of cancer. And to this day, that patient remains in remission as well. So it has, as I said, it has revolutionized the treatment landscape for these patients who were basically had less than 6 months to live, not having any other options. Now, with this CAR T cell treatment, 40 to 50% of those patients are cured, that they won't require any further treatment. They just get one infusion of CAR T cells. It does have some side effects, but they are just in the early days after the infusion and can be very well managed these days. And then they are 40, 50% of them have very, very long-term remission and are practically considered cured. Next slide. Yeah, so this has sort of changed the algorithm for treatment of lymphoma. Now, if somebody is relapsed, if they are a little, if they can get a transplant, still sometimes we consider them for transplant, especially if they're younger. But a lot, treatment is really, really shifting toward CAR T cell for any patient who can tolerate it. And we have been able to give it, even if people in their 80s have received CAR T cell without, and tolerated it well. And also for patients who are not fit for CAR T for any reason, there have been new approvals within the past couple of years. It's a very exciting time to be in the field of malignant hematology. So these, fortunately, it's not like a few years ago, and we have many options to help our patients. Next slide. So this briefly shows the basically the process. Patient comes to the usually either hospital or office. That T cells are harvested. They are shipped to a lab where they genetically engineer the lymphocytes, so they recognize the cancer cells. They grow them, they infuse it to the body, and then the cells will take it from there. They recognize the cancer cells, they start proliferating, they destroy the cancer cells, and if we can show actually a video sort of showing how these lymphocytes work. It's actually a very interesting video showing T cell attacking two cancer cells and destroying them. So yeah, you see that green cell attacking the red cell. The green is the lymphocyte. It's attacking that red cell, and you see that red cell changing shape. It's actually dying. The red cell, the cancer cell, basically dying. The T cell attaches to the cancer cell, and it secretes enzymes and materials that basically perforates the membrane of the cancer cell, and it destroys it. If you can go back to the slides. Yeah, and for example, this is another picture showing how dramatic this CAR T cell treatment is. On the left, you can see all those areas that light up are basically cancer cells. And on the right, you see after CAR T cell treatments, all that has gone away. On top right side, you see all those white areas within the CAT scan, within the lung, are cancer cells invading the lung. On the bottom, you see after CAR T cell treatment, it has all gone away. Next slide. So results have been, there are several CAR T cell products either approved by FDA or in final stage of trial. And actually, we do have a trial right now of lisacabtagene, Marolucel, or the Juno product in RCCA, one of the very few places in New Jersey that can give CAR T cell. And this lisocabtagene is actually one of the next generation CAR T cells that they have made some tweaking to the product compared to the previous products. It's fairly similar, just a little bit of tweaking. They think it's a more balanced product, sort of like all subsets of T cells are given like in the same ratio. And so far, the results that they have presented in the American Society of Hematology shows very, very promising results. And soon it will be approved for, I expect it to be soon approved by FDA. And I'm very excited that we have this trial and we can offer this trial to our lymphoma patients. Next slide. So yeah, that was an overview of, very brief overview of lymphomas and the novel treatments of them. Of course, there is much more to say about treatments of lymphomas. As I said, there have been many new approvals for treatment of lymphoma besides CAR T, but due to constraints of time, we'll just have to move to the next segment. And multiple myeloma. Multiple myeloma after lymphomas, which lymphomas happen like to 80,000 to 100,000 persons in the United States each year. Multiple myeloma is the second most common blood cancer, usually 20 new cases per year. Next slide. So what is multiple myeloma? We talked about B cells. After B cells are exposed to the pathogen, they recognize the pathogen. With the help of T cells, they start destroying the bodies and destroy the pathogens. But eventually, they will morph into plasma cells. That's like the terminal stage of B cell differentiation. It turns into, they give rise to plasma cells. And the plasma cells' function is to secrete antibodies. Antibodies are proteins made by our plasma cells. They attach to the pathogen, and they either directly destroy the pathogen or tell other cells in the body, other immune cells, hey, this is a pathogen, destroy this one. So kind of basically acts like a beacon of sorts. And these plasma cells, sometimes like B cells, they can go rogue. They can become cancers. Next slide. So what are the risk factors for developing multiple myeloma? Radiation exposure. Of course, radiation is a risk factor for a lot of cancers, including multiple myeloma. Chemical exposure. We do have a strong evidence that people who were exposed to Agent Orange have increased risk of developing multiple myeloma and several other forms of blood cancers. People who were exposed to the dust and debris after 9/11, the first responders and people who lived in that area have increased risk. We are just seeing the result of that in terms of blood cancer. Unfortunately, many of those people have developed other forms of cancer, like lung cancer specifically. But we have started to see some evidence that they have increased risk of several types of blood cancer, including multiple myeloma. Some petroleum products, such as benzene and other types of industrial solvents, also are a risk factor. Obesity is a risk factor, not a strong risk factor, but it's there. People who have a family member with multiple myeloma have a slightly increased chance of developing multiple myeloma as well. The hereditary component is not as strong as colon cancer or breast cancer, where certain syndromes have increases the risk dramatically. But there is a somewhat increased risk. Age is a very strong risk factor for multiple myeloma. It's a disease of older people, like lymphoma. more common in men, and more common in African Americans. Next slide. So what are some symptoms of multiple myeloma? Again, the symptoms are fairly non-specific. Multiple myeloma cells, the plasma cells, usually live within the bone marrow. So when they start dividing unregulated, one of the things they do is basically they don't leave any room for other cells in the bone marrow, the normal cells. So the bone marrow cannot make enough blood, cannot make enough white blood cell, cannot make enough red blood cell. So people will become anemic. They will have a fatigue. They will be short of breath. They will start losing weight. They will be prone to infections because the bone marrow cannot make enough normal white blood cell. And there are some unique symptoms of multiple myeloma as well. Basically, bone lesions and bone lesions, fractures, and kidney failure. Now, if we go back to the previous slide, on the bottom right, you see basically the structure of different types of antibodies, these proteins. These plasma cells, when they go rogue, when they become cancerous, they start making too much of the antibody. And this is not an antibody that's useful. It's that fights infection. It's basically whatever antibody that plasma cell has, it starts making it like in very large amounts, and too much of this certain protein in the blood leads to problem. Also, an antibody is composed of two different parts, a heavy chain and a light chain. And specifically, these multiple myeloma people will have like too much light chain production, which can precipitate in different tissues in the body and cause problems. Next slide. Next. So, for example, in the kidney, and this is basically shows like a nephron, which is a unit of kidney. These antibodies, specifically the light chains, get filtered out into the urine. They can get stuck in the kidney, precipitate in the kidney, basically block the ducts, or sometimes they are even directly toxic to the kidney cells, and they can cause kidney failure. And this is one of the symptoms of multiple myeloma. Next slide. The other problem with multiple myeloma is that it causes a lot of bone damage. Basically, as I said, plasma cells live within the bone marrow, and they can they can affect the function of the cells that are tasked with maintaining bone health and bone integrity. There are cells in the body that are tasked with basically remodeling the bone. And these multiple myeloma cells can basically interfere with their regulation. So those cells will end up digesting the bones, the cells that are tasked with remodeling and like maintaining the bone, will end up digesting the old bone and not making any new bone. And this will cause to bone lesions, what we call lytic bone lesions, and fractures if left untreated. Next slide. So this is an X-ray, very typical X-ray of the multiple myeloma patients. And as you can see, those like round lucencies that are like in the femur, and you can see it like in the pelvis in many areas, that's round lucencies in the bone. Those are all lytic lesions. Those are all areas that the bone has been destroyed. The plasma cells are there, like the multiple myeloma cells are there. And it can be both very painful and dangerous if it leads to fractures. Next slide. So until like 15 years ago, options for multiple myeloma were unfortunately limited. There were like until 16 years ago, maybe 2-3 agents were that 2-3 medications that were effective, not very effective, but somewhat effective. And usually a person who was diagnosed with multiple myeloma, unfortunately, had only like 3 to 5 years to live. And in the past 15 years, there has been a very dramatic um, improvement in treatment of multiple myeloma. And right now, it's one of the most treatable source of cancer. It's still not curable in majority of cases, meaning that we start a treatment, patient responds for a long time, then it comes back, then we switch the treatment. Cancer becomes resistant again. So we treat it, but the vast majority of the patients in United States that are diagnosed now can expect to live with myeloma for more than 10 years. And the prognosis is rapidly improving. The CAR T cell that we talked about for lymphomas, they are developing it for multiple myeloma as well. And we have had very encouraging results from the trials. So for most patients who are diagnosed with multiple myeloma, initially we do a combination of 3 drugs, usually, if they can tolerate it. If they are younger, like younger than 75 and fit, we will send them to bone marrow transplant. If they are older, usually not do transplant and continue the medication. And this is the first line treatment. And usually it controls the disease for quite some time. Next slide. In this, you see like all the different approvals and the new medications that we have had for multiple myeloma. It doesn't show things like before, like 2003, because really for 30, 40 years, there was not much. There was just like 2, 3 approvals. And just within the past 15, 16 years, you have this insane number of all these new treatments either approved or in later stage of trial. And taken together, multiple myeloma have many, many good options. In fact, for an oncologist, usually the problem is like which drugs to choose, like how to choose between all these many options. So it's, which is a very good problem to have. Next slide. So that was like a very brief overview of multiple myeloma. For multiple myeloma, as I said, the prognosis have improved dramatically. For multiple myeloma, it might be good to see somebody who is focused on hematological malignancies, because there are nuances involved in the treatment. But overall, I would say that it's a very treatable disease, fortunately, these days. Now, moving to MDS and AML, acute myeloid leukemia, people usually have heard of leukemia, might not be very familiar with MDS, which stands for myelodysplastic syndrome. Next slide. Myelodysplastic syndrome, it's just like a mouthful. It's just like the big Latin words for bone marrow not looking right. And historically, it comes that from the fact that in the past, like many, many decades ago, for these people who were having low blood counts, low blood level, low white blood cell level, low platelet level, they did bone marrow biopsies and they could see that the cells don't look right. They didn't know what's going on exactly at that time because of the limitations of technology. So they just decided to call it myelodysplastic syndrome. And in this picture, you can see like it's basically a diagram of how blood is produced in our body. You have the stem cells in the bone marrow who divide, and each cell that's divided goes through a process of differentiations, and it gets differentiated to different components of the blood. When things break down in this process, when the cells cannot maturate as they should, cannot like basically differentiate to what they should, it's called myelodysplastic syndrome. The bone marrow cells cannot maturate, cannot grow to the normal cells that they should be. Next slide. So what are the risk factors? Age, it's a disease of usually people older than 70. It can happen in younger people. It's quite very rare before age of 50. But previous chemotherapy, all the school chemotherapies that we very much use to this day for diseases like breast cancer, etc., it's very good. It kills the cancer cells, it prevents the breast cancer from coming back. But at the same time, unfortunately, it damages the DNA. And in a minority, like a few, less than like maybe 2-3% of the cases who get those chemos, after a few years, it can cause MDS and possibly even AML. Again, as I mentioned earlier, benzene and the dust and debris from 9/11 has been known to be a risk factor for MDS. Radiation, the same as multiple myeloma, is a risk factor. Smoking does increase the chance of developing MDS and AML. And there are certain hereditary mutations. They are very rare, a small minority of MDS cases. So MDS, the main problem, next slide. And this is basically shows a diagram of what's going on with the MDS. Like usually people, it takes many years from the first insult, the first injury to the stem cell. It takes several years and multiple steps, multiple damages at different points for it to become symptomatic, for it to become like florid MDS. Like different damages that happen by time and chance in the DNA of the stem cells in the bone marrow, sometimes other insults such as radiation or chemotherapy, all accumulate to basically give rise to MDS. And the problem is, there are two problems with MDS. First, the bone marrow won't be able to make enough cells, so it won't make enough red blood cell. People will become anemic, fatigued. It won't make enough platelets, so people will be at increased risk of bleeding. It won't make enough white blood cell, so people will have increased risk of infection. And sometimes it can progress to leukemia, acute myeloid leukemia, which basically those damaged cells that cannot maturate, they will start proliferating and dividing very rapidly, and they fill the body with cancer cells. Next slide. So symptoms. We talked about it, because the body cannot make enough blood, people will be fatigued, they will be short of breath. They won't have enough platelets, so they will bruise easily. They will get frequent infection. And on the CBC, the blood counts that we do in the office, you will see that the blood counts are low. Next slide. So how is it diagnosed? It requires a bone marrow biopsy, which is a procedure that's done in the office. It's quick, it's not painful, or not very painful, to be honest. We go with a needle and take a small sample of the bone marrow. And we send that sample for several kind of tests. Basically, a pathologist will look at it under the microscope. They will do tests to determine the sort of the makeup of the proteins on the surface of those cells. We will test the genetic material of those cells, basically to see exactly what's going on, if there are any abnormalities in the proteins and DNA of those cells, and exactly what abnormalities. Next slide. So after we do the bone marrow biopsy, we do the test, genetic testing, and the see what percentage of cancer cells are in the bone marrow, how damaged their genome is. We can basically sort of risk stratify the MDS, and we will end up with low-risk MDS, either low-risk MDS, which basically has low chance of progressing to leukemia. And the main problem is the main problem in low-risk MDS is people will not make enough blood, so they might need transfusions. We can give them medication to stimulate the bone marrow to make blood. And those people usually have a good survival, they will live with this disease for years. And a lot of times they die of other causes rather than MDS. And on the other end of the spectrum, we will have high-risk MDS. And unfortunately for these patients, left untreated, the survival can be less than 1 year. Those patients do tend to progress to leukemia quickly. And you can see the numbers in this slide, that especially in older patients with high-risk MDS, like the survival is basically around a year or even less. Next slide. So, as I said, for low-risk MDS, there has been actually several new treatments, most of them new, especially the luspatercept, lenalidomide, that can make the bone marrow make more blood and improve the quality of life of the patients and solve the problems. For the high-risk MDS, for many, many, many years, we had only like these two medications, azacitidine and acetaminophen, which are good medications, but they didn't help. They helped only like maybe 20-25% of the patients. Many other patients didn't have any response to it. And the responses to these treatments were not long lasting. So unfortunately, for many years, we didn't have good treatments. Fortunately, there has been many good progresses in MDS as well, especially a new medication called venetoclax. Basically, it helps the cells that are damaged, basically, to recognize that they are damaged. And the cell has internal quality control mechanism. And so when they recognize they are damaged, a lot of times they will die and go away. And venetoclax greatly potentiates this mechanism. And there is a trial with very encouraging initial results called the Verona trial that adds the venetoclax to older medications for MDS, azacitidine. And we actually just opened that trial in our CCA offices. Again, one of the trials that I'm very excited about to be able to offer to our patients. There are other treatments on the horizon for MDS patients as well, especially some sort of immunotherapy and IDH inhibitors. Next slide. And moving to AML very briefly, as I see we are running out of time. AML, the leukemia, basically it happens when the stem cells tasked with making blood in the bone marrow go cancerous. So they start proliferating. They just divide to and give rise to other cancer cells without making blood. So what happens is the bone marrow is filled with cancer cells, and people won't be able to make any red blood cell or white blood cell. As you can see, again, it's a disease that happens in older people, vast majority of the cases older than 70. Next slide. So AML, like since the 70s, when the treatments, we started to find treatments for AML, usually it was treated with very intense chemotherapy regimen that's not easily tolerated. It's quite intense. A lot of times it's effective, but it's very intense, and it was very hard for older people, who are the majority of cases, to tolerate this treatment. It's called 7+3. For many years, people tried to improve on it without any success, up until actually 2017. There were other treatments that were considered, added a little bit, but not meaningfully. But up until 2017, when venetoclax, the medication that I mentioned for MDS, they found that it can be very effective for AML patients. For older AML patients, which are the majority of the patients, usually they cannot tolerate this intense 7+3 chemotherapy regimen. That 7+3 refers like the combination of like two medications. One of them is given for 7 days, one for 3 days. That's where the name comes from. For like patients in their like 70s, it can, yes, most of the time it would be impossible to tolerate that. So we had treatments like azacitidine, which was not very effective by its own. So unfortunately, a lot of times when patients were diagnosed, people like either didn't refer them to hematologists, oncologists, because they knew the treatments are not effective, or they would say like things like, get your affairs in order, like this is like it, this is a there are no effective treatments, and such. And even some of like other hematologists like were very skeptical of like treating older people with leukemia. Fortunately, that has changed. Fortunately, we have had not only venetoclax, several other very effective treatments that are very well tolerated. That I have had patients in their 80s that were treated with these regimens that were very well tolerated. These treatments are not curative. It won't like definitely cure the AML. That can only be done by bone marrow transplant, which is not something that's tolerable for people over 75. But it can provide them with quite some time, like prolong their survival, and with good quality of life, which they can spend with their family and their loved ones. So these days, the main issue is just to change that mentality that like, no, the treatment of leukemia in elderly people can be effective, and it's definitely worth trying, or at least discussing it with the patient and making them aware that there are all these new options for even very old patients with leukemia. Next slide. So yeah, leukemia for a lot of times, like in conferences, in oncology conferences, like researchers in other fields kind of used to tease leukemia researchers that, oh, you just have, you still only have 7+3, like teasing them about like the lack of improvement for more than 40 years. That fortunately that has changed dramatically in the past few years, and now we have an embarrassment of riches in AML, that so we can help the patients. And that concludes our talk. I see, yeah.
Okay, so we probably have enough time for just one question. And so there is one question in the chat. Does the administration of CAR T-cell management always require hospital stay? I have heard that it is extremely intense, like the worst flu you have ever gotten, and you have to be monitored closely for side effects.
Very, very good question. And no, it does not always require hospital stay. The early CAR T treatments that they did, yes, the patient got very sick. And the reason was that those CAR T cells, they were infused to the body, they recognized the cancer cells, and they would start reacting, proliferating very rapidly, making the people very, very sick. When they started giving this treatment, they said, oh God, this is like too intense, it's too dangerous, we can't give it to every cancer patient. Then they found out that there is a medication called tocilizumab, which we can give to control these symptoms. And these days, CAR T is very, very safe. We can control those side effects very effectively. And one thing about the CAR T trial that we have, the Transcend trial, is that because of the improvements that they have made, because of the tweaking that they have made to the product compared to other products, compared to earlier products, actually it can be given outpatient. So we have come a very long way. We give it outpatient. If patients develop severe symptoms, we will tell them, come to the hospital so we can give you tocilizumab and monitor you in the hospital. A lot of patients, like for example, they might develop some fever, which can be controlled like with very simple measures outpatient and don't require hospitalization. Some people might come to the hospital, stay there like for a few days, and be discharged. With the lisacabtagene and marolucel, the CAR T that we are giving, the incidence of those very severe flu-like symptoms have been rare. Like I would say the severe cytokine release happens like probably, I think the number was something like 1% of the cases, the very severe form. So to answer your question, no, it can be done outpatient, and obviously you will need close monitoring, but it's very safe.
Okay, so thank you so much. Thank you, Dr. Kazemi, for taking the
Sure, my
time
pleasure.
to present on this topic and to answer our questions. And
Thank you.
the next topic in this series is pancreatic cancer on November 13th at noon. So thank you everyone for joining us for today's talk. Take care and stay safe. Okay, thank you.
Thank you for joining us for this week's Encore presentation. To join us for live programs or to learn more about the East Brunswick Public Library, visit our website at ebpl.org.